The challenge, of course, is we don't have specific markers yet that we routinely use that can identify what specific endocrine therapy is most appropriate for any given patient. That's the hope, that's the aspiration, particularly when we start getting into looking at different molecular assays, molecular markers, et cetera. So right now, the general approach is if you have somebody that's hormone receptor positive, or their tumor is, we would preferentially treat them with anti-hormonal therapy. What's changed is now, even in the absence of those markers that I was referring to that help us decide who's really going to benefit or not, we have new agents that, when combined with anti-hormone therapy, markedly enhance the time until the disease progresses. And that's very different than what we were seeing with single-agent anti-hormonal therapy. Now, the caveat to that is that there are patients, we all have them in our practice, we've had them for decades, who, when we treat with just single-agent endocrine therapy, some of those patients do quite well for a year, 2 years. We don't know why that is. We don't know who they are before we start. And if we had a magic way of determining that, ideally we would make the treatment as simple as possible and give them anti-hormone therapy just by itself. In the absence of a tool that helps us define who the patients are that are most likely to benefit, we tend to now use doublet therapy, meaning an anti-hormone therapy and one of the newer agents like a CD4/6 inhibitor or an mTOR inhibitor, because it increases the time until the disease progresses. And you do buy a bit more in the way of side effects by that strategy, but in some cases you double the time until the patients develop progression of disease. So that's meaningful to patients. It's not a few weeks or necessarily a couple months, it can be as long as a year. So it's significant. So we try to make changes to the NCCN guidelines based on the evidence available. So obviously a well-conducted randomized phase 3 trial that's well done and arrives at compelling evidence that a new therapy is significantly adding benefit to what's currently available. That would influence how we deliberate and the changes that we would make in the guidelines. So as an example, the palbociclib data, which was generated from 2 phase 3 randomized trials, was very compelling data, and that led us to put those drugs on the guideline. And similarly, the data with the mTOR inhibitor everolimus, when that came out from the Bolero-2 trial, was also sufficiently high quality that was added to the guideline. And I alluded to this earlier, that we're anticipating, any moment that the ribociclib data is likely to be approved by the FDA. And that was based on a well-done randomized trial published in the New England Journal of Medicine. And I think that when we deliberate about that data, assuming it's approved, it is also likely to find its way onto the guideline. So we don't look at every tiny trial or phase 2 trial, but certainly when there's an abundance of data or a very well-done pivotal trial, phase 3 trial, with very positive results, that gets our attention, that leads us to consider it for inclusion on the guidelines. As a general statement, we say that these new drugs clearly seem to add significant benefit, but there are patients where they may not be appropriate. There are still patients, it could be the older patient with very minimal metastatic disease, where the appropriate choice may be anti-hormone therapy. Whereas for the patient that has more significant amount of disease, younger patient, we would almost uniformly use combined therapy with a newer agent and endocrine agents. So even though the data is very compelling and it's found its way into the guideline, there are patients that are still appropriate for monotherapy, and I think you just have to use your clinical expertise and decision making along with the patient to decide what's appropriate for that person in front of you.